We have some time for questions. This time, I think, in the interest of fairness, I'm going to start with questions from the audio participants in the conference. So if the operator could please open the lines.
We will now open the lines for question and answers. To ask a question, please press star followed by the number 1 on your touch-tone phone. To remove yourself from the queue, please press the pound key. Please state your name and organization prior to asking your question, and pick up your handset before speaking to assure clarity. Please note your line will remain open during the time you are speaking, so anything you say or any background noise will be heard in the conference. We have a question in queue from a participant whose name was not captured. Please state your name and organization to identify your line to our presenters. Caller, your line is open. Caller, your line is open.
Good afternoon. This is Gregory from CHA. So wondering if you could maybe possibly check the one mic that has some Dr. Berwick, Dr. Williams, and the last speaker. It seems to me that particular mic is the one.
Excuse me, can you start over again and speak up a little closer into the phone, please?
We were wondering if possibly you could check the mic. We believe that the mic that's being used, that was used by Dr. Berwick and the last speaker, might be the cause of why we are not being able to hear.
Okay, we're very sorry. We'll check those mics again right now. We'll take a question from the floor.
Thank you. Dr. Brock, thanks for a great presentation and congratulations on the success of the work. As we in communities trying to basically take step 1, know who your patients are, what are your recommendations for those of us who do not currently have a Medicare data set for taking an efficient stab at that? Do you have any thoughts for us?
Well, my hope is, there's no guarantee, but my hope is that there's active intention at CMS to make this kind of data much more easily available. We hear rumblings. So anyway, I know that's not a totally satisfying answer, but.
If I could I ask a follow-up?
Of course.
Well, why don't I say something first? I mean, we have every intention, once the program is up and running, to be providing feedback data to hospitals and community organizations about transitions in their communities. But in terms of the startup, since hospitals will have to look at their readmissions based on their own, based on internal data and their own readmissions to their own hospital, unless they can come together with and share data with other organizations, other hospitals in the community and other providers in the community, because we don't have the ability to make community-wide data available, patient-level data available to applicants until they're actually part of the program.
Okay, great.
You had a follow-up?
My follow-up was going to be just based on the data and your experience in the real world, given that the Medicare data won't be available, thinking really specifically about these meetings, and who's coming with what. We're going to have nursing homes, we're going to have home health agencies, all of whom can bring to the table their own populations. Given that messy reality, any specific recommendations on how to use that data well?
So our hope is that this entity that is a community-based organization can become a legal structure where providers can share cross-provider data. I mean, I don't know, that's not strictly specified in the law, but I think there's a fair amount of acknowledgement that within a group of providers there needs to be a legal way to establish a data exchange forum, so that hospitals can know their readmission rate.
Great, thanks.
David Schulke, HRAT. Great work on the project. I think one kudo to CMS that's deserved, in addition to the obvious great work by hospitals and community providers and QIOs, is that CMS in the design of the 14-state project allowed the interventions to be selected by the sites, and that did not mean the QIOs, but the QIOs let the providers that they worked with figure out what they wanted to do. And that's a very powerful way to do things. And it puts, I mean, CMS was under some pressure to define the interventions. And so this was a very, I think, courageous and smart thing that they did. And I think it shows results at the community level. People got to work on things they wanted to work on the way they wanted to work on them. One of the things that the hospital community is concerned about and would like to see as resulting from the national implementation of the 3026 pilot is sharing of interventions that seem to work. So, of course, there may be, I hope there will be a community of practice between the sites, but for everybody else that's not in, as I agree with you, 500 million sounds like a lot, but there's not that many sites compared to all the people that are trying to make a difference here and all that are subject to penalties potentially. So, do you have a mechanism in place for pushing out intervention strategies as soon as they start to show promise, or are you going to start by promoting the evidence-based intervention strategies, RED and the Coleman and Naylor and the other interventions?
It's our intention, as Juliana mentioned this morning, to have a technical assistance contractor who will cull the data from our monitoring of the projects to see where we think we're seeing early successes, to bring the community of participants in 3026 together initially to share those results, to learn from one another what's working, what seems not to be working, how things can be tweaked, how things have been adapted to particular circumstances. And to build on that, and in fact, participation in these collaboratives will be a requirement for participants in 3026 because our goal is to spread the learnings from this. And then we are working actively with our colleagues in the Office of Clinical Standards and Quality. I can do acronyms, but I like to pronounce for people who don't live in my world of alphabet soup. Anyway, we're working very closely with our colleagues to figure out how to take the information then that we develop from this project and use the QIO program in the 10th scope of work to begin to spread those learnings more broadly across the community of hospitals and other providers so that we're not confining those learnings to ourselves. And I think that in combination with OCSQ and in combination probably also with our Innovation Center, that we will be doing a lot more in the way of spreading the learnings from this project as well as from other things that we're doing. Good question. Thank you for asking.
Thank you.
Hi, I'm not going to tell you who I am because I have yet another annoying logistical complaint request. The last great presentation, Dr. Brock. The last few slides, however, are not in our notebook. And they were the best stuff, including the web link to, the evidence publication. So if we could somehow make sure we get that.
If they're not already on the website fully, we'll make sure that any additions get added to the website.
I think they are on the website because I got them from the website this morning.
Okay, they are on the website. Any other questions? Do we have any other questions from the audio participants? Operator, if you could open the phones.
Your next question comes from the line of Joanne Handy. Your line is open.
Hello, I'm with Aging Services of California. I'm really fascinated by your outside-in approach, which I'd contrast to the more inside-out approach that we heard in the earlier presentations. I wonder if you could comment on two aspects. We heard earlier that it's all in the execution, and the execution among so many different players is indeed difficult. What were your observations about the actual execution of the evidence-based tools in your projects? And did you observe that there was one provider type that often took the lead in the community coalition?
So let me answer the second question first. There often was a single provider or provider type that would step up within each community. But I would say across the board, we think there's many different possible models for doing this. And that's why we say, I think the strongest strategy is to get your community together, figure out who's in it, both in terms of who needs services and who supplies services, and negotiate that locally. I think that in the end, that was almost our biggest learning. In terms of outside in, I think you're probably referring to the fact that we did this through community coalition work. Is that right? If that's not right, correct me.
Yes, yes.
In the beginning, we didn't necessarily intend to do so, but within a couple of months, it was just obvious that that was going to be the best way to do it. And so I think that's one of the reasons that this is being framed as community-based transitional care, because we think that's what works. And we were so fortunate to go forward with visionaries at CMS who had a suspicion that it would go this way from the very beginning. It's just been very powerful.
This now concludes the Q&A section for this segment of the agenda. I'd like to thank Dr. Brock and I'm sorry. I'm looking at announcing the next people, and I lost track of myself here. Anyway, I'd like to thank both of you, and I'd like to bring up our next panel.